Hi, everyone. This is one of the few times I think I'll need a mic because I've lost my voice, which is terrible. But, you know, go Raptors, right? Actually, I was on a flight yesterday. I just flew back from Berkeley, and half of the plane, of course, was dressed in, you know, it's a San Francisco to Toronto flight. Half of the plane was in full Warriors, like everything, you know. And when we landed in Toronto, the pilot said, "Oh, everybody, it's so nice that we landed in Canada. Go Raptors." And the half of the plane that was Warriors were like booed, and they started chanting, and I was very embarrassed for my countrymen. So I am going to talk to you today about learning healthy models for healthcare. I have never been introduced with like all the titles, so I feel very prestigious now. But I will say I come from a computer science background, but during my PhD, I spent a lot of time working with doctors, and this was in the Boston area, but primarily at Beth Israel Deaconess Medical Center. And what I sort of noticed while I was working with them is, you know, a patient would come in, and two doctors would have very different treatment recommendations. And so I would ask them, well, why do you have these differences? And they said, well, you know, we don't actually have that much evidence. You know, when we're practicing, a lot of this is based on who we've seen, what we've read, you know, there's a lot of calls to make. And so and there was one statement that a doctor made that really stuck with me. He said, you know, we really know only what to do when you're at your sickest, but we don't understand what it means to be healthy. Because as a society, we define healthy as an absence of interactions with the healthcare system. So you're healthy when there's no data on you, which means we have no idea what that means, right? So there's this huge variability. So right now, what we use as a gold standard for treatments are randomized controlled trials. That's our evidence, right? So what happens is you recruit a study population, you learn a rule with statistics or machine learning, but the question that you should be worried about is, does this generalize, and for whom does it generalize? And these were statistics that were new to me as a PhD student in computer science, but the doctors I worked with thought it was hilarious to, you know, send me these papers. So the first statistic is, what proportion of treatments that are used in hospitals today do you think are based on randomized controlled trials? Right, that's our evidence, right? So hopefully a high proportion of these should be based on RCTs, but they're not. So very few treatments are actually based on randomized controlled trials because they're expensive, they're hard to run. And then let's take something where randomized controlled trials were run. So asthmatics, there was a set of trials that was run to figure out what sort of treatments are optimal. But the question is now, there are lots of people who have asthma. I think it's 1 in 8 North American adults is diagnosed with asthma. So how many people who currently have asthma could have been included in these randomized controlled trials that were used to design their treatment? You would like that to be high, right? But actually 94% of patients would have been excluded. They would not have been allowed to participate in the randomized controlled trial. Only 6% of current asthmatics would have. And so what you should be concerned about is whether the things that we learn actually are robust to a wide group of individuals. So maybe we can use machine learning to learn what's healthy, right? There's a lot of data that's out there. Maybe it's not just randomized controlled trials. Maybe we can use medical records, but also all of these things about the environment, about your genome, about the internet, about mobile data usage, about your social network. This is all how you interact with your environment, and so maybe this is also health data, and we can learn what it means to be healthy by using all this data. But medicine is not new, and neither is machine learning. And so the reason this hasn't happened yet is because this is actually really hard. Unlike a lot of other fields where machine learning has revolutionized some tasks in those areas, this data wasn't gathered to answer a hypothesis. We didn't go out and create a resource like ImageNet for vision, where you take a lot of photos of things and you have an army of people label those things, and then you say, aha, object recognition, it's a task, let's do this, right? So this data was actually created as we were providing care. And so that means that it's often heterogeneous. There's lots of differences in sampling, data type, and timescale. There's a lot of sparsity, which is a really hard thing in machine learning in general. But specifically in medicine, the thing that we often come up against as a machine learning practitioner is we don't have a lot of certainty about anything. Right, so there's uncertainty about all the things you might usually be uncertain about in vision, for example. How much noise is there? You know, do I believe that the lighting is okay? All of the things about the input data. But specifically in medicine, we don't know our labels, and that's something that's very unique. So in medicine, you can have two patients, and you can say that they have, a diabetic diagnostic code of some kind, but that could mean that they've been diabetic for a really long time, and you're just catching it now. Or it could mean that the diabetic code was mistakenly entered, or in the US, it was entered because you needed to bill the insurance for the test to determine if they are diabetic, so they're not diabetic. Or it could actually mean that they're diabetic. It could be all those things. And so it's hard, and even if we take the retrospective analysis of a code out of it, there's also the issue of diagnoses and conditions are assessed by experts in medicine, but experts are allowed to disagree. So this is not true, for example, in a lot of vision cases, right? So if we're asking to label chairs, everybody's an expert in labeling a chair, and experts are not allowed to disagree about what is a chair, right? So the other thing that's really challenging for me is that there's not a lot of expertise in the reality of what machine learning can and can't do, what's easy and what's hard. And so often what happens is people will tell me, and it still happens even though I've told people that this happens to me and that it's silly. People will say, well, I have the data and you have the machine learning, and together, we can fix this. And I'm like, no, it doesn't work that way, because machine learning can be very confidently wrong. So these are famous examples from the vision community. They're old, right? These are from 3 or 4 years ago. The top row is showing you what a deep neural network, state of the art, believes is a canonical king penguin, starfish, freight car, and remote control. And the bottom row is adversarial pixel, which is when you adversarially click one pixel and change the color. The state-of-the-art neural networks think that a ship is a car, a horse is a frog, and a deer is an airplane. And those are the confidences in the parentheses, right? And granted, this is with access, it's adversarially done. You're trying to fool it, right? And you can ask the neural network, why did you get this wrong, right? What's going on here? And there's ways to explain a decision in a neural network. So for example, this husky was misclassified as a wolf. And when you ask the neural network, why did you think that this was misclassified? It will tell you, well, there was snow. You've never shown me an example of a dog in the snow. They're always in other environments. And so I thought that this husky was a wolf because you had snow. That's the explanation. And we can all sort of say, oh, that makes sense, because all humans are usually experts in natural language processing, speech recognition, and vision, right? If I ask you to evaluate a sentence or a recording or an image, you can do that. But the issue within medicine is we're not all natural experts in medicine, right? And even doctors are not experts in other doctors' sub-areas. And so when you artificially attack, so this is an adversarial attack, just the way the pixel was, where we inject the perfect amount of random noise into a chest x-ray image or a picture of a mole, and then a melanoma or a non-cancerous mole and both a pneumothorax and a normal x-ray, the classification is flipped. And the state-of-the-art algorithm is completely confident in the wrong diagnosis because we adversarially perturbed it to be that way. But it would be hard to detect because none of us are natural-born experts. You'd have to ask an expert that has been trained. So now that I've depressed you, I I'm going to talk to you a little bit about why I do machine learning for health, some of the things I'm excited about, and convince you that you shouldn't be that depressed, actually. So mostly I'm going to focus on what models are healthy, and then I'll talk a little bit about the other two very briefly, and I think we have time for questions at the end. I'll go through this relatively quickly. So most of the work that I do is with the MIMIC-3 ICU data. So this is data that's available from the Beth Israel Deaconess Medical Center Hospital. It's available to anybody in the world. All you have to do is take the equivalent of the Tri-Council Policy Training, which is called CITI in the US, CITI, and prove that you are an academic researcher, submit your credentials, and then you get access within a week. 40,000 patients worth of data, and it's all of their data. It's notes, labs, everything. And this is important. I'll come back to it at the end because it's really set the stage within the machine learning community to do state-of-the-art machine learning on medical data. So here's the generalized problem description that I often deal with. You observe a patient's data, and it looks like that. And then you want to do some sort of real-time prediction so that if you play a record in pseudo real time, you see how well you would do at predicting the need for a drug, the onset of mortality in the next 24 hours, or some sort of important condition by some gap time before the doctor would have acted. And I say by some gap time because once a student told me, I can predict mortality with 100% accuracy, but what he had detected is that if you turn all the machines off, people die, which is true, and you can predict with 100% accuracy, but probably not that useful. So here's the first thing we start with. Let's predict something important in healthcare. So this is, maybe what a computer science student would start with. So here's what we did. We tried to predict mortality with clinical notes. Why mortality? Because it's a good proxy for acuity. Acuity is not something we have a good continuous measure of, so probability of mortality is our substitute. Why notes? It's because doctors really look at the notes, right? So when I would see the doctors come in for morning rounds, they would look through the notes first. And so we wanted to say, hey, like they're relying on these. Why haven't machine learning people used notes at this point, right? This is when I started my PhD, and they don't use them. We don't use them because they look like this. They break all of the standard natural language processing algorithms. If we think doctors' handwritings are bad, their notes are worse. It's much harder to decode. I'm just letting you guys know. Computers can't read it. So we took the notes and we did a form of natural language processing called Dirichlet allocation, commonly known as topic models. All it does is a generative model, so you don't give it labels. It learns based on the probability of the underlying data itself. And it tries to learn a way to generate the data that it observes based on an understanding of topics that it also learns. And so here, all you do is give it the notes, and then it learns potential topics that could have generated those notes. And importantly here, you don't tell it, learn things that predict mortality. You say, learn topics that would generate the underlying data with a high probability. Once you've learned those topics, you can confirm that they're correlated with the thing you care about, in this case, mortality. So baseline mortality in MIMIC is about 11%. And you can see some topics like the ones that look like respiratory failure are enriched for mortality, and some topics like the one for cardiovascular surgery are actually protective. So you see mortality rates of 30% in respiratory failure, and one's closer to 1% for cardiovascular surgery, which both make sense. And then we actually put these topics into a regularized prediction algorithm and said, okay, now in real time, every 12 hours, try to predict who will die in the next day. And we found that the gold standard, which is using acuity scores like SAPS and SOFA, which are standard ICU acuity scores, gender, ethnicity, and age, actually in the blue line do worse and worse over time, which makes sense because those numbers get stale, right? You assess them and they don't really make that much sense when you're 48 hours into your ICU stay. But the topics which are shown in the red line get better and better. They get more predictive of mortality over time. And when you use them together, that's the green line, you do best of all. So that's really great. This was a fun thing to do. It was the first paper out of my PhD in 2014. But it's now 2019 and the AUCs, the accuracies, are the same. And I want to say that last model there, which is the current state of the art, it's what we all benchmark against, GRUD, is actually a very clever and complex model, but it's not doing any better. So this is a gated recurrent unit neural network that actually explicitly captures missingness decays per variable, but it's not doing any better than shown in the red box. Really, a random forest with simple imputation, because there are some things that more complex machinery don't actually work well to capture. And so from this problem, which maybe doesn't benefit from more complex modeling, we moved on to let's predict something actionable in healthcare, right? What are you supposed to do if somebody's going to die? Maybe there's a palliative care transfer that you could talk about. But then we said, let's try to predict interventions. So let's try to predict some common interventions in the intensive care unit. So again, we use the mimic ICU patients, we use their static data, the time-varying vitals, and the clinical notes processed the way that we talked about. And the important thing is if you process clinical notes in the way that I described, is now just a matrix of numbers, right? Of the proportion of your note that belongs to different topics. The labs and the vitals are already numbers, that's already a matrix. And you can replicate the static data over time, and now that's a matrix too. So all of one patient's data is in a matrix. That's important because now across all of the hospital data, we have a big tensor. And in machine learning, we have models that work really well at predicting onsets with underlying tensors of information. And so we can train switching state autoregressive models, which are another form of generative model that tries to auto-regress, that tries to predict future values based on past values. Or we can train two different kinds of neural networks, both recurrent neural networks, which are long short-term memory networks. So these are predicting things over time using just the last hidden state, or convolutional neural networks that look at trends in the past k time steps and try to predict onset in the future. And the cool thing is neural networks work well, right? So we were able to predict many different kinds of interventions, both invasive and non-invasive ventilation, need for a vasopressor, different kinds of fluid boluses with high accuracy. And you can also ask those models to be interpretable in the same way you can ask for a vision network to try to explain why it made a decision. So you can look at feature level occlusions and say, aha, physiological data like lactate levels and pH are more important for the need for an invasive intervention, but actually the topics, what kind of words a doctor or nurse has entered in your note, make more sense to try to predict a fluid bolus need. And maybe that's because there's more provider preference allowed in these less invasive interventions. And you can also look at the convolutional filters and say, look, these short-term trajectories that are most activating for the need for an intervention, they make sense with what we understand about physiology. But the thing that we transitioned to after that, so that was a really cool thing, and we were excited about that paper, about that result. But we were getting some people wrong. So for whether somebody needs a vasopressor, right? We would often predict that they needed the vasopressor to be taken off, that they could be weaned really early. And so this is the histogram of how early we were predicting for some patients that they could go off the vasopressor. And so we said, maybe we need to have a more aggressive cost function, maybe we need more advanced machinery in our model. And the doctor we were working with said, maybe not, let's look at some of those records. Because patients can be left on interventions longer than necessary. And so this is an example from Mimic of a 62-year-old male who had a cardiac catheterization. And the line you're seeing there is the probability that our model thinks that you could be weaned. And as it gets high, that means, oh, wean this guy, he looks like he could be weaned. And then the notes there are the actual clinical notes that the nurse typed at those time points. And so when the model is low, you can see the note says low central venous pressure, rising hematocrit. This person still needs to be on the pressor. When the probability of a wean gets lower, you can see that she says, well, he's hypovolemic, there's a low central venous pressure, increasing need for the pressor. Right around when the model goes hot, at hour 15, the nurse writes, attempt to wean off today. But that patient is not weaned until hour 45, a full 30 hours later, so more than a day later, when the blue line ends. So this patient probably could have been weaned earlier, but maybe there were some conservative care estimates, maybe there were other things going on, right? And so the issue from a machine learning perspective is, that's the label for my model. When I tell it, predict who can be weaned, How does it know who can be weaned? It's supposed to learn from when patients were actually weaned. And so there's this challenge when we're working with medical data that is not easily solved. In the same way that when a model makes a mistake on a dog, we can say, oh, don't be confused by snow. It's fine, dogs can be in snow. Here we have to make a decision. Could this patient have been weaned? Is this a mistake? How do we count this? So the next thing we looked at is maybe we don't want to just predict these interventions, maybe we want to predict actionable insights in healthcare. So maybe what we'd like to do is forecast responses to an intervention. So when I give you the pressor, as an individual, I'd like to know what kind of response you're going to have. So this is actually really hard to do because in order to predict this, you can imagine what you might need. You need to have an example of Marzyth before the pressor for 6 hours, 12 hours, observe all my physiology, give me the drug, and then have an example of Marzyth after the pressor for 6 hours or 12 hours, right? We need these examples to say before and after, learn how people respond. That's not how it works, right? Very rarely do you have a sufficient amount of data before and a sufficient amount of data after. So you have to work with a very small number of paired examples where you have both before and after, and then a much larger number of examples of just people before, physiological states before they get a pressor, they never get the pressor, and then physiological states of people where you didn't get to see them before. Maybe they came in on a pressor and so they're already on the drug. And so to do this, we use adversarial training. So we use generative adversarial networks, which you've probably heard of because they make those crazy real looking faces. And the way that they do that is they look at lots of examples of faces, right? And so this is how you've probably seen they age your face, right? So there's the Snapchat filters. They can make your face look really old or really young. And the way that they do that is they have no idea what you look like, older or younger. But they do have a lot of ideas of what lots of people look like when they are older and younger. And so they can use that information to figure out what is the manifold, what is the vector that takes people from old to young, and then apply that to a given face. And in the same way here, we learn the vector that seems to take people from untreated with a vasopressor to treated with a vasopressor, and then we can apply it to people. And so we learn on this unpaired and paired data. We actually have very few samples of people before and after, only 500, but we have 3,000 examples of people who are either only before or only after. And by using this, we're able to lower the mean squared error, so very accurately predict what the individual physiological response of a patient is going to be on a ventilator and also on different kinds of vasopressors. This is also really cool. We were really excited about this. But one thing that you should think about is, would you deploy this model? Right? I'm hoping you're all going to say no, right? Like I get approached really frequently actually by like startups and they're like, let's deploy your models. And I'm like, no. But it's hard to tell them no because they're like really excited and they keep calling and you're like, no, go away. So there are other factors that we should consider because these things don't exist in isolation, right? So the next thing that we wanted to do is create actionable insights, not just predict something, but create actionable insights in healthcare. And so here, we talked to doctors and they said, you know, we don't just want to predict or forecast a response, that's kind of interesting, but really what do we do? We're gonna look at this individual signal that's hard for me to read. Can you create a report? Can you give me something that I'm used to looking at? And so our most recent paper, it just got accepted, yay. Our most recent paper automatically generates radiology reports given an image of a chest x-ray. And so you show the algorithm the picture of a chest x-ray, and then it writes the report for you so that you can read it and edit it if you need to. And so here we're using actually a lot of machinery to generate this because you have to both process the image using a convolutional neural network, try to decode the sentences that might have been generated using your current neural network, re-encode them, and then both optimize for having that templated structure that we see in radiology reports and having a diverse amount of text because you have different things that are written. And so our model, using reinforcement learning as a reward for being able to generate different kinds of diagnoses, is able to maintain high language fluency, meaning humans can read it, right? And also, it's more clinically accurate on 12 different chest X-ray diagnoses than current state of the art. So this is great. We were really excited about this result because it's something that you could imagine could be useful by somebody who's practicing. But the thing that, so you know, maybe the startup would say, aha, this one, we're gonna deploy this one. Still, you should maybe put the brakes on, and that's because we want to ask what sort of impact any technology we deploy has on the human relationships in health. Because healthcare is fundamentally an interaction between humans, right? And we also want to make sure that the technologies that we deploy, they help eradicate the known inequalities we have in healthcare and they don't exacerbate them. And so briefly, what I'm going to cover here is what kind of healthcare is healthy? And what I mean by that is bias is already part of a clinical landscape. So it's well studied within the clinical epi world that biases in society are reflected in biases in healthcare data. And so if there's something that you know that humans are biased against, you'll pick that up in medical data. This is across many different factors. So the issue is, if we improve healthcare, we should probably be improving it for all people, right? But we're also learning on data generated by humans. And so remember the first paper, the 2014 paper, you know, like, oh, I predicted it better, you know, that's so nice, right? I was asked this past year by a doctor, you know, did you check that you do just as well in different groups? And I said, well, I included that data in my model, so obviously it's fine. And he said, well, maybe you should just, you know, check. And so instead of just saying healthcare, let's try to create some actionable insights in human health. Because if you look at the topics that are most enriched for different kinds of ethnicities, genders, and insurance types, it's different. You could say that's fine, right? Maybe it is the case that more women have COPD or more men come in for substance abuse, right? Like that's something that was in the data, right? Maybe there's just more of it. But what's probably not okay is that our models have different accuracies, unfair accuracies at predicting the things that we want them to predict based on group status. And you probably would not want to deploy a model that does worse on people with public insurance or on women, right? And so the issue here is when we optimize a model to do best across everybody, based on the data that we've seen, it might not do best across particular groups. And that's something we have to decide that we want to deal with, both in a societal way and in a technical way. So my group does creating actionable insights in human health, and that's some of the research that we've been working on recently. This is my team of fantastic students and collaborators. They're all great. And now I'm going to tell you very quickly about some of the things that I think, so I've told you a lot about all these challenges. Everything is hard, right? But challenges are actually secret opportunities, right? They're things that we need to make better. And so we're working on things like unknown unknowns, right? So we are trying to do fundamental research in when I learn what happens to cells, for example, in the presence of a drug, can I hallucinate what would happen to any cell in the presence of any drug? Or complex data challenges. So can I forecast what kind of prediction models will work well across a policy change? If a hospital changes the way it's coding something or the way it's reimbursing something, can I actually make a model robust to that? And finally, robustness to the unseen. Because if a new condition comes on the scene, I probably need to know that I'm not well calibrated to make a prediction, because new things are going to arise. So the last thing I'm going to cover really quickly, because I do it all the time now, and how many people here are Canadian? Most people? Most of you, you're all, okay, that's great. I have a set of things that I think Canada should be doing since I'm a new Canadian. I had to take an English test. I have like a 200-page PhD thesis, and I was required to take an English test. I'm very offended. But as a not yet Canadian, because I'm waiting for my English test results, these are things that I think that Canada should be doing. So Toronto has a limited time to lead in machine learning for health. The reason that we could lead is because we have the perfect mixture of technical, sports, and medical talent. A lot of raw talent here, obviously, guys. But currently we're limited by our vision, right? We're not pursuing this aggressively enough. And this field moves really quickly. So machine learning is growing really aggressively into the healthcare space. So these are the list of our conferences, which you have to publish every year. You know, we submit like 3 to 4 papers to these conferences that have less than 10% acceptance rates every year, and they all have healthcare subsections. So I'm co-chairing for NeurIPS this year, which is the premier machine learning workshop or conference in the world, and there's going to be at least one healthcare workshop. And last year when we ran the healthcare workshop, it had 500 people in it. These are all people from around the world who do state-of-the-art machine learning, who are using healthcare data. Eric Topol's paper and book demonstrate that on specific tasks, there's wide applicability of machine learning across the human lifespan. So we can define things that we would want a machine learning algorithm to do, and then it does very well at those things. And machine learning is already being considered a regulated advice giver by the FDA. So at least 12 additional AI applications have been cleared since 2018. I think it's a total of 26 to date. So companies are clearing their algorithms with the FDA. The FDA is evaluating them to make sure that they do as well or better than a human would do in that specific task, and they're cleared. I think we are in a really unique position to promote robust machine learning in health, because the Toronto area is large, has all of this raw talent for computer science and medicine, and has a really diverse population that has access to a single payer system. And so we are uniquely positioned to say, if an algorithm works well in Toronto, it could work well anywhere in the world. There's really no other place that could say that. And I think the world is getting wise to this, so people in the States are starting to pool their data to try to make sure that they can have these kinds of guarantees. So that's why I think we have this limited time frame to really push forward. Also, I gave a talk to a bunch of tech CEOs, and one of them said, so basically what you're trying to do is make all doctors the best, like Dr. House. And I was like, did we watch the same show? He was a terrible doctor. He was a drug addict, like he was mean to people. So I think that, so this has been well reported, that currently doctors spend a lot of time on things they don't want to spend time on. The algorithms aren't coming to like replace doctors and take over healthcare, but they could come to fix things that currently doctors have to do, but probably shouldn't have to. Because if 35% of doctors are reporting burnout at a level that they are unable, they think they are unable to make a personal connection with a patient. And over half of doctors are saying they don't have time to be empathetic, but all it takes is 40 seconds, right? You just have to like really engage with the patient. And there are demonstrable benefits. There's a real thing that could be addressed. There's real advantages to be had by using machine learning where it could improve healthcare. The second thing, and I have to say, like as an American, where everybody talks about race all the time in the US, right? The fact that there is no race data in Canada like took me by surprise, and it took me a full week of asking every doctor I know in Canada personally, like, come on guys, it's hidden somewhere, right? Like there's a federal database, like you collect it, but yeah, it's hard for me to access, to believe that it's not collected. And that's because I've worked with American data, which has race in it because of the Civil Rights Act, because you have to be able to verify that structural inequality, that racism right, is not creating different healthcare outcomes for Black mothers and white mothers. I mean, it is, right? But you have to be able to confirm that so you can address it. I've also worked with British data from the NHS, where because of the anti-racism laws, you must also report race. This is self-identified race, the same thing that we all had to fill out in that StatsCan survey that we got sent. There's 12 of them, or you can choose not to report. The fact that we don't have it is an ethical liability because we need to be able to, actually investigate where we should improve. It's also a technical liability. It's a technical liability because if I build a machine learning model, remember that graph I showed you where I said, oh, look, it does unequally well across people of different genders. I can't make that graph with Canadian data, which means no other country will ship, the FDA won't clear my model because I cannot verify that it does equally well on people of different ethnicities. So this is a huge liability for us that we should be addressing. And the technical fix is simple, right? It could be something that you report on your OHIP card, that's private information anyway, but it's something that researchers should be able to use to confirm that care is being provided in fair ways so that we can verify models to be shipped internationally. And the reason that we should have this kind of data is we know that human treatment pathways are shockingly, at least to me, unique. So you could say, well, we have enough data, it's huge, and we know we're diverse anyway, right? How do we really need to do all this checking? We do. So George Herbshack at Columbia somehow collected the claims and electronic healthcare record data from 11 sources, 4 countries, 250 million patients, and did a very simple analysis of, for people on diabetes, depression, and hypertension, or for people with diagnoses of diabetes, depression, and hypertension, what medications are you on in a 3-year time frame? So maybe I'm on medication A and stay on that for the whole 3 years. Maybe you're on A and then D and then B and then C and then Z, right? That's all he looked at, just that string of medications. So how many people do you think, what percentage of people do you think are unique? Nobody else had that string of medications. For diabetes, it's 10%, which again blew my mind. For depression, it's 11%. And for hypertension, it's 24%, which means if you ask the question in an underlying population of 250 million people, based on my 3-year treatment pathway, what patients are like me, the answer for a quarter of hypertension patients is nobody. You have 0 nearest neighbors. And so treatment pathways tend to be very unique. And we need to be able to characterize them across things like gender and ethnicity. The final caution I would say is we know that models, very high capacity models, if you allow them to cheat, they will. So this model is lazy. It's learned that hospital A, which has a higher rate of a specific diagnosis, uses a particular little nodule in their chest x-ray machine. And that's being used as a proxy. So it's able to detect what hospital a chest x-ray comes from with 95% accuracy. We probably don't want that to be the thing we learn in our models. And so we need to be explicit and say, don't learn different models by ethnicity, make the model fair. The final thing is, I would say that health data is one of the resources that we should take advantage of. So all data is valuable, we know this, right? We hear it all the time, data's the new oil, la, la, la. But actually, health data is really valuable because in a for-profit system, you can use it to learn models and then sell that back to people. And so that's what companies like Amazon and Google are doing right now, right? So they're buying data, lots of data, 750 million patients worth of data, actually. And then they're making models, and they're going to sell that back to you. We should be creating research with resources. Right now, there is one data set that the entire machine learning community, all of us use. It's the MIMIC data set, and it's because it's easy to access if you are a vetted researcher with appropriate training. MIMIC has been around for over a decade. There have been no lawsuits, no newspaper headlines, no privacy failure. It was de-identified, and then vetted access was provided because individual patient consent was waived as the study does not impact clinical care and all the data is de-identified. When I run my class at University of Toronto for computer science PhD students, I train them using American data. I train them using this data. So all of them are using this data to predict the interesting and important things. It's what the whole world is using. And it's using this because this is what's available. And so I think as Canadians, we need to decide that we want to create resources like this, because if the whole world is learning machine learning models, including Canadian professors at Canadian universities training Canadian students, are using American data because that's what's available, that's what we have real access to, then we're going to make models that work best for Americans, not for Canadians. And the mimic model really works. So the thing that I was most impressed by is there were $1.3 million in funded NIH grants based on work that happened in Mimic in 2018 alone. So this is actually creating real science. And so we should be creating resources that can allow us to compete, because arguably we have better data. We just have to decide to use it. And the final thing that I'll leave you with is what has happened in other machine learning fields. So there's two fields I'm going to tell you about. There's computer vision and computer speech. So every machine learning department in the world that's like top ranking hires a theory machine learning person, you know, a person who does text, a person who does vision. Nobody hires speech people anymore. Nobody. Toronto hasn't hired one, MIT didn't hire one, Berkeley hasn't hired one, Stanford won't hire one. Why don't they hire them? They don't hire them because the data is not available. It's owned by companies. When computer vision became a big thing, Fei-Fei Li at Stanford released the ImageNet data set so that everybody in the world can do state-of-the-art machine learning research on the same data set, and they can publish their research. But speech is owned by Amazon for Alexa and Google for Google Home, and those data sets are private, and nobody's created a speech data set. And so we are actually incapable of training state-of-the-art models in a public setting. And when a student comes to me and says, I want to do speech, I tell them, you can't get a PhD in that anymore. So you have to decide, we have to decide as a community whether we want machine learning for health to be like speech or vision, whether we want a student to come in and say, I want to do machine learning for health, and for me to say, you have to go work for Google to do that, because that's where the data is, or whether we say, yeah, those are public resources. We have vetted researcher access, and actually the state-of-the-art models are made by university researchers, so let's do that. And obviously I would advocate for the latter, given the fact that I'm a professor, but thank you very much.
Excellent presentation. I'd like to open the floor for questions from the audience. We have a few minutes before the break. If you could please go up to the microphone that's on the edges of the...
My question is regarding in your first slide, one of the first, you were talking about the randomized clinical trials, and that is really very structured study to be the high top evidence really. So what will be the impact of artificial intelligence for better design of the clinical trials, and what will be the way to with Health Canada in Canada these things can be done better?
I think that clinical trials are necessary, but I think they also give us incredibly limited information, right? So the FDA, I think just 2 years ago, forced you to include women in your trial. Bad idea, guys. Like, why did it take that long? Why did it take that long? I think that the promise of artificial intelligence is to augment randomized controlled trials. So if we can observe in hospital data that women who are given vasopressors to get their blood pressure up to a rate that we think it should be, based on a study that was done in men decades ago, don't have great outcomes, that should suffice as reasonable evidence, right? Especially if it's done in a population of millions of people. And so I think that there's a huge opportunity to say that, and there's a big argument actually in the statistical community about what amount of observational data and what kinds of learning approximate the effect of a randomized controlled trial. So I think that there's many methodological improvements that we can talk about in terms of causal inference, trying to adjust, because the wonderful and beautiful thing about randomized controlled trials is that randomization arm, right? And so we don't have to do any of the more advanced statistical learning for randomized controlled trials. But if we say that we have a data set that's large enough and random assignments to hospitals, for example, right, across different geographies, there are some methods that are trying to approximate that effect estimation.
Thanks. I really enjoyed your talk. I was just wondering if you could predict how Canada's socialized medicine might play out into your models, because there are probably tests that we are giving or not giving based on our socialized healthcare system, and how that would affect your modeling and prediction.
That's an excellent question. When you're learning on real data, any absence of information cannot be explicitly included unless you know to put it in there, right? And so if there's a test that, for example, is never given in Canada, we won't be able to determine the efficacy of that test. And so the way that we can move beyond that, I think, is by pooling and merging data with the United States, the United Kingdom. So the UK has the UK Biobank, right? And other resources that are coming online. In the US, we have MIMIC, and there's also Project Nightingale for more longitudinal data that's coming online. And I think these kinds of comparison studies are actually going to be really important, because there was a really nice paper that I think might have been done comparing the life expectancy of people in the US and Canada for maybe cystic fibrosis. And they found there that I think a lot of these more aggressive or invasive diagnoses, treatment, they don't seem to be helping, right? I'm sure there are some that do help, right? But we need to be able to ask and compare. And you're right, if the data's not there, we can't actually learn it without a comparison.
Thank you.
Thank you for that talk. I enjoyed it very much. In the first half of your talk, you were talking about using AI to help make treatment decisions in the ICU. I was wondering how available the technology would be, or how available the technology is to do that in real time, and what kind of investments would need to be made to make that infrastructure available.
So it depends on the hospital. So within the EPIC system, right, it's FHIR enabled, right? So FIHR, that kind of FHIR, right? So you can deploy apps within the system. So if the model actually learns based on data that is there, you can deploy an alert. So Suchi Saria has worked with the Johns Hopkins Center. They have a real-time sepsis warning system that's based on her algorithm. I talked to Mark Sendak and Catherine Heller, who are in the Duke system. Duke has a real-time sepsis early warning system. Kaiser Permanente has deployed across, I think, 3 hospitals at this point, early warning systems for a variety of different conditions in the ICU. I'm collaborating with Mohammed Mamdani and the CHART team here at St. Michael's Hospital to see if we could deploy a similar early warning system here. And there's so many different kinds of ways you could imagine giving this information to somebody. You can imagine having a separate system that takes in data in pseudo real time, right? Maybe we're making predictions every 6 hours, right? And then it has a risk score, and it alerts a separate staff member who then looks at the original data and makes a decision about, okay, what do I want to actually send this alert to the care team? You could imagine sending that information directly to the care team, the risk scores. You could imagine having it display within the EHR. If you have EPIC, if you have a system that allows you to display extra information with FHIR, or you could imagine using a pager. You could imagine, using something completely separate. And so I think nobody has figured out exactly what the right solution is. I know the Duke team actually sends the alerts to the care staff. The NYU team, this is Yann Yiannopoulos. I think they send it to not the care team generally, but very specific staff members. So I think there's a couple nurses that have specific training to get the information. But Kaiser Permanente has a separate team, like an EICU team that they send the alerts to, and the EICU team makes a call or sends a referral to the system. So I think there's a ton of different ways to implement these kinds of models. It just sort of requires deciding what's going to work best and maybe, looking at workflow.
Okay, thank you very much.
Time for one or two more questions. Go ahead.
Talk, really enjoyed that. I want to get back to the question of randomized controlled trials, and I think that there's a problem of the bias that you can't get rid of until you do a randomized trial. And I wonder whether a model in the future might be, in each of the teaching hospitals, we randomize almost every patient who comes in, and then use the data sets and the analysis that's in the background, as opposed to the expensive to do a clinical trial. I don't think you'll ever, well, you may not be able to get there from here without the randomization because of the unknown biases.
I think that there are so many unknown biases, right? And so this is, there's a causality lecture that I teach in my machine learning for health class in the computer science department. And the first thing I tell the students is, you will never have ignorability, which is the true understanding of all of the causal factors and all the confounding gone. I think you can get pretty close with things like randomization to hospitals, or you can assume that, if you look at similar days across a couple of weeks, right, you're the doctor that you see, as long as you have knowledge of how doctors are assigned within that hospital. You can look at randomization of care staff. You can look at hospitals that have different practices for very specific conditions like sepsis, right? So I think that you can get there with specific conditions, because in a lot of cases, there shouldn't be strong biases. It's hard to ever say, and in case there are any causality people in the audience, they might kill me later. It's hard to ever say that you have real, unbiased, randomized assignment, because you could say, maybe this hospital turns away all women when they walk in, and so they have to go to this other. It's possible, right? And so I think that we can get very close to randomization and to looking at these approximate effects. And when you have the numbers that we have of patients that go into Toronto hospitals, that gives you this huge boost. And so you can get stronger effect sizes by saying, I think it's mostly randomized, but I also have significantly more data. I have millions of records that I can learn from, and that can give you some of the signal strength you need.
I'm just thinking if patient A gets treated with drug A and patient B gets treated with drug B, there may be a underlying reason that no matter if you have 1 million patients or 10 million patients, you can't get there from here. And there was the women's health study was a good example where they followed. It was I forget what drug they used, and if you looked at the historical data, it looked like the drug was effective, but it turns out it was related to the fact that the women who used that were more active and took better care of themselves. And you realize afterwards what the mechanism was, but it's an unknown at the time.
I think that's the estrogen study, maybe. Yeah. So I think that there is some danger in making strong assumptions if we can't capture causal effects, right? But I think in that particular study, if you would have included socioeconomic status, you would have gotten pretty close to removing the causal confounding there, because that was one of the big problems. I think it's hard in some healthcare systems to include data like that. I think it's possible here. I think actually the advantage of the single payer system is we could get incredibly close to unconfounded data if we're able to include some of those proxies.
One last question, please.
I just wanted to note about the rise of these medical devices which allow people to measure their own biomarkers like HRV and stuff like that,
Do you mean like vitals or like labs?
Rings, yeah, HRV, and people can measure their own stuff, their own data, and then they can use that to direct, how they handle. Basically, it's empowering them to handle their own health.
Right.
Yeah, I don't know if you have any opinion about this, but
I have some thoughts on this. I think that the issue with wearable data is that often we don't know how close it is to other devices, right? So often what we've made, so there was this really good Freakonomics episode about the original thermometer that was used to assign what a normal human body temperature was miscalibrated. Who knew, right? So what this means is, right, if you have a thermometer of some kind, right, and you're, measuring your temperature, it's giving you something else, you might freak out and say, oh no, I have a fever all the time, what's going on? Or you're too cold, you're a lizard person. But I think that the issue with having a ton of data is it's hard to interpret even the data that we have. If I gave you, so I am very much pro the empowerment of patients. They should be able to release their de-identified data to research studies. They should be able to request their electronic healthcare record easily. I think all of that is true, and I am a strong advocate for it. I don't know that I have the capacity by myself as I'm flipping through it, right, to understand what it means that my HbA1c was this here and that here, but what did I eat before that one? And was this just on a bad day? Or what does this mean? I think that we could have models that help to interpret those things. But again, pertinent to some of the RCT style questions, right? We have to have way more information than just the wearable data, because the issue is you have some companies in San Francisco, not to call anybody specifically out here, there are some companies in San Francisco that have deployed like watches, right, that record all the stuff about you, and then they write papers about how they're able to detect this. Have you been to San Francisco? It's 90% white and 80% male. There are like no women in the street. Like I had my kids there, and it was like an endangered species. People pointed at them. Like it's crazy. It has the lowest kids per capita in the United States. So if you're doing a study, right, with all these wearable data, right, you might not learn what you want to learn, right? Because just like in the estrogen study, you're learning an effect for women who have disproportionately more access to this resource and just are better in control of their health. And so give me all the things, I want all the treatment. Well, it looks like they're doing better. That's because they're rich people who want all the things and all the treatment, right? You might have the same issue here, right? So this is my concern with wearable data. Until we have wearable data that actually covers a larger swath of people, it's really, it's super biased right now, even more than any other kind of healthcare data, right? I think we can't say how valuable it is. It could be super valuable. It could be amazing, right? I would be super excited to look at it, but right now it's really narrow.
So let's thank the speaker one more time. Amazing.